Hello, everybody. So I'm going to give a brief PowerPoint description of harm reduction and problematic substance use. My name is Mike Ma, and I'm a member of the Department of Criminology at Kwantlen Polytechnic University. And this will probably be a short 20-minute PowerPoint presentation. So let me share my screen. So as I said, my name is Mike Ma. I'm a member of the Department of Criminology, and my area of research is in substance use, also anti-racism, and also human rights. So there's basically 10 things that I want to talk about today in relationship to harm reduction. Um, and I think it should be a good, if you will, general primer for most people. I'm going to assume that you don't know that much about it. Some of you will know more than others, but I'm going to try and treat the issue as if you don't know that much about it. So number one, what is harm reduction, right? Well, harm reduction is about reducing harm, basically drug addiction typically, reducing drug addiction harms for people who are not abstaining from drug use, right? They're not abstaining from the harm that might be happening from problematic drug use. So this is the question. Can you help a substance user use their substances? So a drug user, can you help them use drugs, but in a healthier way? So it's almost kind of not that simple a logic to follow, right? Because the idea is in harm reduction, we're treating addiction as a disease, right? Meaning it's similar to people who are addicted to alcohol or addicted to gambling. And so it's a medical model for treating disease, right? How do you reduce its harm, right? Harm reduction. How do you mitigate the harm? Number two, this is interesting, right? We're trying to reduce harm for people who are not stopping from using the drugs. Because logically, you would think you would just make that person stop. That would be the healthiest thing. Well, what if that person doesn't want to stop? How would you still support them, right? What if someone doesn't want to stop drinking? How would you support them? If someone doesn't want to stop smoking, how can you support them? So that's the idea. The idea is they don't want to stop. How would you support them in being healthier, right? Can you help them consume their drugs in a healthier way, right? So the whole model of harm reduction is meeting people halfway where they are. You treat it as a disease. Addiction is a disease, right? It's a medical model, and you try to mitigate its harm. You're not trying to stop them. Eventually, you might hope. I think you hope they will stop maybe using in a very extreme or damaging way. But at first, you're meeting them where they are, where they're at. One of the reasons why harm reduction has been suggested or has been advocated by harm reduction advocates is because, very simply, dead people don't detox. Eventually, if you did want someone to go through detox and withdraw and eventually stop using drugs, if it is very harmful to them, you can't get them into detox. You can't get them into harm reduction. You can't get them into treatment, a residential treatment facility. You can't get them to these places if they're dead. So the whole idea is to stop people from dying. How would you do that? You have to, I think, not approach it with a pure kind of simple rationality. You have to have compassion. And you have to have compassion because problematic substance use is very problematic. It's not easy to solve. If it was so easy to solve, everyone could be able to solve their problems by themselves, right? They would just snap their fingers and their problems would be solved, right? So it's so problematic that it's not easy to fix, and therefore you have to approach it with compassion. And that is what harm reduction is. Harm reduction is really another word for compassion, right? And also, I think sometimes people forget that withdrawal symptoms are a very, very strong mitigating factor, right? People don't want to actually maybe stop, not least of which because the withdrawal symptoms could be very painful. So they're they're adverse to the pain because they remembered when they stopped using something, they felt like they were sick, like as if they had the flu, like as if they were going to die, right? So do you want to experience those feelings? No. So part of the, if you will, fear of detoxing and then going into treatment is the withdrawal symptoms. Also, another reason for people to use drugs, I think it's very well documented, is self-medication. People want to use drugs because they have a problem that they're dealing with, typically a mental health issue, or maybe even a physical ailment that they're using, if you will, drugs to help, if you will, self-medicate. There's a famous doctor called Dr. Gabor Mate, and he's written extensively about how almost every patient that he's seen in the downtown east side, in terms of Vancouver's very famous area for chronic problematic substance use, that all of the patients that he's seen have actually early childhood trauma. So these are people who've had trauma and they're self-medicating with substances. So that's another reason to maybe have a harm reduction perspective. Where does harm reduction come from? In the BC context, it comes from this notion of harm reduction as part of the 4 pillars. The 4 pillars are very simple. Many years ago, coming up to about 25 years, we see that harm reduction was originally proposed by Philip Owen, who was the mayor of the city, and Donald McPherson, who was working at the Carnegie Center. He's since moved on to Drug Policy Canada, and then he's also now retired from that. But these are 2 people who put their heads together and says, we can have a system of addressing problematic substance use, and at that time, the problem of overdose. We can have harm reduction as part of 4 pillars, meaning one component of other components. So in addition to harm reduction, you would have treatment, you would have prevention or education, and then you'd have police enforcement. So the whole idea was, it wasn't harm reduction alone by itself operating, but rather it was operating in concert with these other pillars, right? So you'd have to have 4 pillars to keep up to hold the table up, to hold the chair up, right? You can't have 3 legs or 2 legs or even 1 leg. It would only work if it was one of 4 pillars. I do think, though, before, and I'll stop there in terms of the description of harm reduction, and then now kind of criticize harm reduction. Harm reduction as a term might be perhaps overstuffed. There might be already too many things that we associate with harm reduction. At first, we say reduce harm, not to stop it entirely. So that makes sense. Harm reduction. Okay, that makes sense. Meeting people where they're at. But also at the same time, we're also helping people use drugs, right? We're saying, here's some sterile needles or sterile equipment for cooking or for using, or for smoking. Harm reduction also refers to stopping an overdose, right? So often you'll hear now reference to overdose prevention sites, right? So we're this idea of preventing overdose. But actually what we're doing is we're asking people to come to these places to consume illegal or illicit drugs, and then watch them if they have an adverse reaction, if they have a reaction that they don't want, which is like they collapse, and then you would intervene, and then you would stop the overdose, right? So harm reduction also means stopping overdoses. Harm reduction also means, in some respects, detox, in the sense that maybe you're thinking, we can get you into a supervised facility where you can withdraw with assistance and then be cleaner after maybe 4 or 5 days of painful withdrawal. So that's also, I think, the imagination of, if you will, harm reduction, or that it will lead you to harm reduction, to so-called detoxing. Or harm reduction is also understood as opioid replacement therapy. So one of the most common drugs that we associate with harm reduction is heroin. So this notion of it being an opioid, it's a natural organic opioid. It's grown in poppy fields in Afghanistan. And so this idea is, can we get people off of heroin, this opioid, and replace it with something else? So sometimes we replace it with these other drugs that doctors can write you, called methadone or Suboxone, which is a synthetic opioid. or hydromorphone, which is organic, which is basically heroin, or another chemical form of the derived from the poppy. Or harm reduction is also, could we get you actually on a medical grade prescription program, the so-called HAT program, a heroin assisted therapy, meaning we get you on heroin that's written and supervised by a medical professional. So we're not trying to get you off of some other drug. We're saying you can stay on the drug that you want, but it's supervised. So these are all different, if you will, ideas that I think, associate with harm reduction, but they're all associated with the thing I have listed here at the bottom, that it's almost anything except abstinence, anything than trying to directly intervene and get you to stop, right? So it's about supporting you and trying to get you to a place where you might want to stop, or maybe that you continue using, but under medical supervision so that you don't harm yourself. So it's one or the other, right? It's certainly about this notion of compassion and supervision. Yeah, I think that maybe I'll skip over this here in this slide. I just wanted to say that I think actually maybe there's a fifth pillar in the sense that detox, this notion of supervised withdrawal, could be understood as a stepping stone between harm reduction and treatment before you can actually go into a treatment facility and do the kind of therapy that's needed so that you can fix the original problem that you have, which led you to your problematic substance use. But I'll skip over that. Yeah, and also 7, maybe I'll skip over this as well. I just wanted to say that there's quite a lot of studies to show that heroin-assisted therapy, meaning having people stay on their preferred opioid, is actually, the results in some studies show that is better than replacing the thing that you're addicted to with so-called opioid replacement therapy like methadone, Suboxone, hydromorphone. But we can discuss that more in class. What are the illicit drugs that people are addicted to? Well, certainly heroin or diacetylmorphine. Fentanyl, this is the new synthetic opioid made in a lab. It doesn't need to be, if you will, farmed in a field. Cocaine, prescription opioids like Vicodin, Percocet, morphine, crystal meth, crack, which is another form of cocaine. Methadone itself is also circulated as an illicit drug. Oxycodone or Oxycontin, which is very famous now because of the lawsuits against the Sackler family that you may have heard about. There's a Netflix a series about it. Amphetamines or benzodiazepines, that's a huge problem now, because now we see that benzodiazepines, or basically sleeping pills, have been introduced also into the illicit drug supply, and is very, very problematic. And those were the injection drugs, and it's very similar to the smoking drugs in the sense of you can smoke cannabis, powder cocaine, crack cocaine. You can smoke sleeping pills, prescription drugs, heroin, fentanyl, carfentanil, crystal meth, oxy. You can smoke all of those things. And then, of course, you can drink things. And so this is, when we're thinking about drugs, it's a very, very wide landscape, because you can also be drinking so-called non-beverage alcohol. There are people who are addicted to alcohol and not able to afford alcohol, so they're drinking like cooking wine, they're drinking rubbing alcohol, mouthwash, hand sanitizer, anything with alcohol in it, right? So that's also an addiction that people might have, a very problematic addiction, because some of those things are not very healthy for you to drink. And then lastly, there is this notion of safe supply. So a lot of people within the harm reduction sector, advocates for the rights of drug users, are arguing that people should have access to a safe supply. Safe supply meaning they should have access to basically medical grade substances. That's what safe supply means, because the idea is that people have been accessing a poison drug supply, a supply of drugs, because it's not supervised. It's not a controlled substance. There's no, if you will, the government supervision of its production. like there is for alcohol and tobacco, and now cannabis, it's a poison drug supply, right? So the idea is we should replace it with a safe supply. Another issue now, I've mentioned it earlier, now we have basically tranquilizers and sleeping pills that are now mixed with drugs, which creates a huge issue. Fentanyl also has been sold now for probably 20 plus years. So I think for a while we were talking about fentanyl poisoning the heroin supply. But now when we look at stats, we can see that the supply of heroin is like this, and the fentanyl is going up and the supply of heroin is going down. So if you wanted to buy heroin on the street, it most likely is no longer available or very, very difficult to purchase. And then also the last issue, I think, is what does it mean if a drug user wants to use, if you will, synthetic opioids like fentanyl, which has been understood as the poison, right? What if they want to access fentanyl because that's all they've been able to access for the past 10, 15, or maybe even 20 years, or certainly in the last 5 years? And organic opioids like heroin is no longer available. So what does it mean if drug users want the more, if you will, dangerous and the more available drug? So that's these are, I think, common issues that we can talk about. Here's an image I just want to leave you with. What often people think about overdose prevention, and Narcan or naloxone kits often are associated with harm reduction, and that's one of them. Also, it's not just in injection form. You can also get naloxone in so-called nasal form so that you can spray it into the nasal passage. And I just wanted to finally leave you with a quick timeline of community advocacy. How did we get here? I think one of the important things to understand about harm reduction is that it's something that has been advocated by many, many community social justice advocates, drug user groups, and drug user advocates, people fighting for the rights to consume and to consume safely or to consume with less harm. One of the historical, I think, events or moments in this timeline we can see is the creation of DAYAS, the Downtown Eastside Youth Activity Society. DAYAS was very famous, created by John Turvey in 1989, so over 24, 25 years ago. And that idea was, at that time, people were quite worried about AIDS and HIV and other bloodborne diseases like hepatitis C. And the idea was people were sharing needles because needles were in short supply. So the idea is maybe we can have a needle exchange where people gave a dirty needle and then they got a clean needle in return. So that was DAYAS, a very important kind of first moment in a harm reduction and a drug user advocacy in the city of Vancouver or in the Lower Mainland in general. IV feed happened a few years after that, when groups of, because there was an overdose crisis then in the 1990s, people were dying of overdose. Groups of drug users got together and started to create, if you will, a club or space where they could meet and talk about their issues and support each other. And then that's how we started to get, if you will, an actual safe injection site. So this is IV feed is one of the first safe injection sites when people were using injection drugs, which then morphed into VANDU, the Vancouver Area Network for Drug Users, which was run by peers, people who were drug users. And this is an office that they still have located on Hastings in the Downtown East Side. We also have later on the Dr. Peter AIDS Foundation, which was supervising, if you will, HIV patients that they were treating with an injection room. So you can see that based, I think, on what's happening kind of in the community, it's having also an effect on the medical community. The user community is having an effect on the medical community. So alongside, you start to have developed a kind of medical model of how to support injection users or illicit substance users who are injecting those drugs. And then eventually we have the most famous case, which is the opening of Insight by the Portland Hotel Society. This is a site that looks kind of very homey, as you can see, kind of like with IKEA furniture. And the idea was that people could use drugs here, and there would be a nurse in the middle. You can see in this picture of that kind of island there. They could watch people inject and consume drugs, and if they were overdosing, they could intervene immediately and then revive them and stop that overdose. So that was the harm reduction. And at the height of its use, I think there was like 800 users per day. And then that site eventually got a Supreme Court exemption. They originally opened without any legal exemption, but there was a Supreme Court case in Canada which then said, because of the, if you will, the rights of drug users and their safety, they were given an exemption. And so this, when they first opened, this was illegal, but then eventually got an exemption from the criminal code saying you could do this, even though outside of this room, it's illegal to do so. So that was very important, because then that started to give drug user advocates some, if you will, momentum. We see also the health professionals getting on board. This is a crosstown clinic with Dr. McDonald there in 2005 that opened in the downtown east side, which is again another supervised injection place, but not just supervised. They're also providing medical grade heroin or Suboxone or hydromorphone or other, if you will, opioid replacements, but supervised. So supervised under a medical professional, which is different than something like this. This is Connections, which opened up many, many years later. But here you see the picture of Suboxone. That's an oral tablet that you can take, a sublingual that you put under your tongue, right? So that's different. So I just want to show that here are two models. One is opioid replacement therapy under medical supervision. Here is which as an injection, and here is shifting people to a oral tablet away from injection. And then about 10 years later, almost a decade later, Dr. Perry Kendall here on the left, who was the provincial health officer, who's the who predates Dr. Bonnie Henry. Here he's declaring a public health emergency, because you can see on this graph on the left, on the right, that from 2011, 12, and then up until 2015 and eventually to 16, you can see these overdose rates really skyrocketing. And so Dr. Perry Kendall declared a public health emergency, saying we have to get around this, because as we know now today, 6 people die every day in this province due to overdose. And so that was the beginning of this crisis. And that led to basically other sites. And this is a picture of Surrey. And here you can see that SafePoint was opened a year after that announcement. It also received an exemption from the federal government, and there's 6 booths here. And that then also was followed a bit later on by the legalization of cannabis. And I'm showing this to show that something changed, I think, in the political imagination of Canadians, where we started to understand that addiction was a disease, and that certain, if you will, substances could be, if you will, legalized, such as cannabis or marijuana, and not just decriminalized, but also a legal framework for its consumption. And then Dr. Bonnie Henry, who I think know well from the pandemic, recommended that we actually begin to decriminalize. So it's even further, decriminalize all controlled substances for personal use in 2019. And why decriminalize? One of the reasons we can see why we should decriminalize is very simple, and I think people will appreciate this right away. $200 for a gram of heroin in BC, but it's $3.80 for a gram of heroin in Switzerland, where they have actually decriminalized it, and where you can get a legal prescription for heroin, for heroin addicts. So the reason why we might want to decriminalize would be the difference is that the $196, that profit all goes to criminals, right? So decriminalization is also another way of saying we don't want the criminalization the criminal profits to go to criminals and hence supporting criminal activity. And then lastly, here we see other kinds of more kind of innovative, if you will, solutions. This is something that was spearheaded by a professor at UBC, getting people who already have a history, a long history of opioid use, opioid disorder use, and to get them to be part of a program, but no longer having to necessarily access that, if you will, controlled safe supply through a clinic, but rather through almost kind of like an ATM machine, right? So there's kind of different innovations, different ways to deliver perhaps safe supply, or if you will, supervised medical grade substances that you're addicted to. In this case, I think they're dispensing hydromorphone. And then lastly, most recently in the news, as recently as just this week, the police arrested 2 people from the Drug User Liberation Front, DULF, which was a compassion club that opened a few years ago. They were advocating for, if you will, a safer supply, which actually I believe affected, if you will, the types of pilot projects that we see now happening in this province, which is this 3-year pilot that we're undergoing, which began on January 31st of this year, where the federal government granted this province an exemption from the Controlled Drugs and Substances Act, right? So it said, okay, people can now possess 2.5 grams of drugs, of these drugs, cocaine, methamphetamine, MDMA, and opioids. You can possess 2.5 grams of these things and not be in the transgression of the criminal code. You won't be criminalized for it, right? However, as I just said earlier, some members of DULF were arrested as they were pushing and advocating and trying to help, if you will, provide safe supply. And as recently as just yesterday, there was a large demonstration in the downtown East Side, reminding people that since Dr. Perry Kendall announced the state of emergency, 13,000 people have died. 6 people have died every day for the past, I guess, 8 to 9 years. And so that the argument is we really have to have a safe supply. Okay, so that's my presentation on harm reduction. I hope that it's given you some food for thought, and we can continue this discussion when we meet in person. Okay, thanks very much.